Bennett, broadcasting from Miami, Florida. Tonight we have the pleasure of having Warren Wiechmann, MD from University of California at Irvine, a medical education innovator who first started changing the medical curriculum with the iPad, but now he's beginning to integrate the use of Google Glass into exposing the students to it. And we're looking forward to hearing about his experience there. We're also joined with a late arrival, Raphael Grossman, Maine, Bangor, Maine. Warren's gonna basically describe his background and what he's doing now. So welcome, Raphael, and welcome, Warren.
Great.
Thank you.
Oh, thanks,
Warren,
guys.
Warren, can you? Sorry to interrupt you. Can you? I always ask the docs this because Raphael and me, we all have different backgrounds as far as computers and stuff. And since you're so into computers now and the things that it does, when did you first get an interest in computers?
Gosh, I can't even remember a time when we weren't involved in technology in my family. My mom was very into computer learning. She was an engineer. My dad was an engineer. It's something I always grew up with, and it was always a nice sort of release. I think John and I were talking a little bit earlier about how I got kind of involved in this area, but a lot of it stemmed from me being sort of a disillusioned undergraduate bio major who was very tired of the competitiveness, and I took a whole different approach and used my last year after I got all the bio requirements out of the way and focused on digital arts and graphic design and multimedia, and actually held off applying to med school for a little bit of time to focus on that kind of work and web development and getting into that space before I went into medical school. And ever since then, I've stayed very heavily involved in development throughout medical school and sort of kept that technology focus. And it sort of paid off. Over the years, I've sort of kept my foot in that space, and after fellowship and as a new faculty member, a position opened up to get more involved in this with medical education, and so the opportunity was great to follow. So,
Where'd you go to med school in UC of Irvine?
Yeah, I've been at UC Irvine for quite a while. It sort of helped combat my me being a junior faculty when I could say that I've been there for about 15, 16 years, but I've been here from undergraduate all the way through fellowship and now faculty training. So it helps a little bit give me more gravitas for someone who's only been out of training for about 5 years or so.
Yeah, we could probably spend an hour talking about how you integrated the iPad into the curriculum, but when did you first? Just one quick question. I'm curious. When did you first realize that hey, this iPad can be used, to base the curriculum around, the medical curriculum around? When did you first start to think that way?
It wasn't until I actually got my hands on the device itself, and that's when I realized after exploring with it and playing with it, and that was right after it came out this was around June of 2010, so only about a couple months after it had first come out, and conceptually the idea of a tablet wasn't really well defined at that point in 2010, and so until I had about a day or two to really play with it, it didn't sort of impact me of what this potentially could do for just large volume learning, whether it's medicine, whether it's law, where you just have a lot of information concentrated in one place and trying to get nimble with it and match learning styles. It didn't really happen until I got my hands on it, but that was quickly followed by us hopping into a program like that. So,
was it a hard? I mean, to convince the faculty and administration to change, or was it? Or are they kind of computer savvy, and it wasn't a hard sell to the administration?
It really, we were very fortunate, and I'm sure that Raphael could probably attest to this as well, that it's not just you as an individual that has to have an interest. It has to be someone also in the upper echelons of the organization that also share a similar vision. For us, we were lucky to have our dean extremely supportive of technology and the one that sort of pushed this through, and he oversaw the iPad curriculum for 4 years, and he was integral in getting us to move forward with Glass as well. But I've, in the 4 years we've been doing iPads and starting with Glass, I've talked to numbers of programs that had great people on the ground that wanted to make it work, work, but they couldn't get the buy-in from above. And so just, if you're in a very lucky position to have that kind of support, you need to take advantage of it, because it's not a commonplace occurrence just yet. So.
And when were you first exposed to Glass, Google Glass?
Actually, that was almost a year ago when I saw Raphael over at Stanford, at the Stanford Medicine X conference. I saw Raphael on the panel there. I'd always heard about it. I'd wanted to see more. I've seen some of the articles at that point, but then just sort of hearing them talk about their stories and their use cases, that became sort of my moment where, for me, it solidified that this has a great potential, not just in the clinical part of medicine, but in the medical education, the core part that I kind of live and breathe right now. And I pulled Raphael aside just to shake his hand and get to know him. And it's just sort of great following him. But that was really the moment where I thought we really need to do this. And it took a while to get it implanted at UC Irvine, but like I said, that was the moment. So it's awesome to have Raphael here and just to be able to thank him for providing that inspiration and getting us forward there. So.
Raphael, had you already done that first operation where you, I guess, showed the medical students what we were doing on the table?
Yeah, I believe that was after Stanford was in September, I believe, and the operation was in June. So yeah, it's first I should say thank you, Warren, because it's nice to hear that from you, and not that I want any recognition for anything ever, but I think it's for me it's a personal sort of good feeling to I mean, I'm a teacher as well as you are, and to me have someone who maybe you inspired some way, exceed anything that you can ever, or all that I thought was possible and more that is still possible. And I know that you and your organization will get there, because like you said, it doesn't. It's not about dreaming. It's about having the infrastructure and the people above running the show in a way to really dream with you, so that things can come true. And right. I think that when I saw your name on the paper, on the news about what you guys are doing, I was so excited, because it is possible, it is intuitive, it is doable, it is the natural evolution of the platform. There's nothing fancy about Glass. It's just the new platform, and it's just about dreaming how to use it and just going for it. And it's really great to see what you guys are doing, and I'm proud. It's really.
Well, Warren, now you've given us the students, and you said prior to the show 10 students have it. You give it to the students. What exactly do they do with it?
Right. So it really depends on if you want to sort of break up our program into the two parts that we have. So there's the clinical part, which they use in the 3rd and the 4th years, and that's when they're on their clerkships, they're in the hospital, and that's sort of a mixed bag experience, and I sort of describe it that way because it really depends on what that team is doing. And so I sort of think of them as devices for a team. So if they're on trauma surgery, it's going to go to the trauma surgeon or whoever's scrubbed into the case. They'll be using it, and the students can follow along from there. Or if the student's going to do a procedure for the first time, they'll put them on. And so it's very sort of fluid on who's going to get the device actually, and who's going to wear it, and who's going to be viewing. But I think that's kind of the neat part about it, that you can have that fluidity and flexibility in what they use it for. We've probably done more in the past couple of weeks just because of the schedule in our 1st and 2nd year. And so for us, this is the classroom heavy component. It's a lot of sim lab. It's a lot of clinical skills center environments, for all the things that are tied around, whether it's your patient doctoring course or clinical foundations course, whatever your course is called that has that, where students are learning the basics of the physical exam. And we use a lot of it then. So actually just yesterday, not yesterday, but today's Monday. I'm forgetting my days of the week right now. But last Friday, our last day of the school, we had an OSCE, the structured clinical exam with standardized patients. And so we've been using Glass in that scenario for putting it on a standardized patient, so having them record and or broadcast the encounter. So they're actually, the standardized patient's wearing them, recording the student for the first time, and we're getting a really unique perspective from there. And so we've been doing a lot of those sessions to see what kind of data we can get out of there that's different than, say, the standard, bird's eye view camera that's in the room. Trying to look at engagement, empathy, body language, those kind of things that really can put patients off from physicians. You may be a very brilliant physician, but if you roll your eyes after everything they say, it's not going to do you a whole lick of good. So these are the kind of things that early interventions on those subtle cues are trying to look at.
Do you look at the videos are the videos recorded of what the student sees, or how does that work?
Right, so we've been trying it both ways. We've been trying it just streaming, using we are working with a company called Pristine and Eyesight, and using their software to do the live stream from the glasses. So we've been using that as a couple options to do the live stream, but we've actually found in those environments the recording tends to be a little bit more useful, because then we can kind of go back after the fact and do debriefings and really run through those videos. And so right now our students really don't have a lot of opportunities to view videos of themselves interviewing patients, and so now we're trying to put more of these clips in the student's portfolio, so to speak, so they can really see, wow, I look that way when I interview a patient. And for a lot of them, it's really, at least anecdotally, it's been very eye-opening to that perception, or that image that they project on the patient.
Mm-hmm. Raphael, do you have any questions you want to ask?
Not really, not specific questions. It's just a delight to hear how you guys are doing, and I've been following closely what you guys post, and again, I think that perspective of having glass, not just a provider, or
Right.
Just having the patient perspective. It's
Mm-hmm.
it's another field that it's sort of untapped, and I think that having the patient's perspective used to teach is a phenomenal idea. And the same way, in a clinical setting, having the patient's perspective to show us how we are doing, or to maybe have the patient check on data that we want to share with them as we tell them about the data. I think that that's a very unique way to also apply this incredible technology to healthcare and to medical education.
Right.
So I'd love to, I love what you guys are doing. I wish I wasn't that far from UC Irvine, and I could come visit and check out, hands-on what you guys are doing, because it's phenomenal.
No, you're absolutely right, Raphael. It's great because it's something that we couldn't easily do before. I mean, we've all had big Polycom infrastructures or similar infrastructures in our institutions, but those are $7,000 a camera, $10,000 a camera. It's a giant piece of machinery. It really just takes away from when you have glass there, and even when you throw it on a standardized patient or even a real patient, you sort of forget that it's there. The patient forgets that it's there. It just sort of blends into the background, and you get this really unique perspective, which, right now when we're, if you look at just the overall state of healthcare, those sort of things, patient satisfaction, engagement, how do you really engage patients to sort of maintain their health outside of your visits, those are things that we never talk about in medical school, and we just hope that these students are bright enough to handle it on their own, but we hear enough stories where people aren't engaging properly, so something has to be done, and this might be a way that we can get a little bit better at being physicians again. So,
absolutely.
Is there? I guess you've used it. Students have used it in all the rotations, the clinical rotations, or just certain ones.
Yeah, so it's primarily used more in the procedure-based specialties. So, surgery naturally, OBGYN, emergency medicine in the ICUs, and anesthesia. We're trying to, we just switched blocks today, so we have a couple students that really want to use it in primary care for, either doing like teleconsultation, or even just having being able to capture really interesting video snippets of great pathology or abnormal physical exams or other things. That's the other thing that we've started trying to do more and more in at least the clinical environment is, one of the challenges in the first and second year is trying to get more clinical relevance, more clinical correlations into the lectures. And so we sort of have a running list of desired pathology or normal findings from our basic scientists, and so now we can have that as a running list that when someone's in clinic, if they say, I need to look at a good ingrown toenail, instead of just snapping a photo, they can record a video, kind of do a quick 1-minute walkthrough of what an ingrown toenail looks like, or an abnormal neuroexam, or Bell's palsy, those kind of things. We can actually capture them a lot easy. And sure, you can do that on your phone or just a camera, but for us, and Raphael, you might have noticed this too, the fact that it is glass is making a lot of people excited about doing it. We've told them before, hey, use your camera and document that, and they said, no, that's too hard. But now we have glass there. Everyone said, oh yeah, I'd love to just put them on and capture a video or two. So it really helps break that barrier down.
Absolutely, I think glass, glass in a way, it's such a buzz about glass. So people is intrigued, is excited. It's sort of a sexy tool, and everyone, even if it's silly, they want to do it. They want to. So I think that factor is very important. I think for some of the applications, and some people that would not record, with a camera or they would be more than glad to put glass on and do something with it. So absolutely.
Right.
Well, what? That's one of the things. I was just briefly talking with Warren before we started. Initially, when I first started interacting with you guys that use it in the clinic, I thought it would be just basically a surgical tool that had a small use, but I've seen it in many areas. Like I'm sure you've seen it grow in the last couple of years. Many areas, even in like Warren mentioned, primary care, the Augmetics up in San Francisco, where general doctors are using it for patient visits.
Right.
That is, do you have any experience with that, the recording of it? And well, I guess you don't, Warren. The students don't have to do medical records. But how about you, Raphael? Do you have any experience with the dragon part of recording? Are you getting involved with that at all, or no?
Well, in a theoretical way, I've tried a whole bunch of applications out there that people have sent me to try and to give an opinion. I was lucky to meet the Augmetics the guys, Ian and Pello, very, very early on, and same as I met Pristine, the creator, a while ago, and there are other places out there. There's Dr. Kronos, for example, which is an EMR application. Dr. Kronos has a very at least theoretically, very useful app, a platform for glass, and I think that that is just the beginning. I think it will be much more fluid than it is right now in every sense, and it's only going to get better. So I don't have any clinical experience, unfortunately. I've been very limited to what we can do clinically here because of the HIPAA concerns. We are working on a couple of projects, one for home care and one for emergency ambulance services, and we have the protocol or the pilot all ready to go in a way, and we just need some grant money, to a very small amount, to basically get it going. But again, it's different when I'm at a 400 plus bed hospital, tertiary, but it's a non-for-profit, that doesn't have many of the the handles and the resources of a place like UC Irvine, but we dream big, and I dream big, and I've been pretty much independent in regards to this glass issue. I've been, since I was the first one who ever used it in surgery, that gave me a lot of sort of leverage to keep talking and keep traveling, and I've been really trying to inspire people like when I met Warren all around the world, and I've been lucky to
Right.
go visit countries around and just give my ideas and then give opinions and then try out stuff that people want me to give an opinion on. And hopefully soon when the HIPAA concern is not such and it's easier to bypass that HIPAA concern, just like Beth Israel Deaconess is doing, like people who's using Pristine is doing, then we'll start using it clinically, and I think that will be just the beginning of of the rest of our lives, like the movie.
Right.
Warren, now 10 students use it now at Irvine, correct?
Yeah, we have the 10 devices. Absolutely. Yeah.
Do most of the students want to use it, or is there going to be? Is there a demand? Are all the students going to get it eventually? Do you think?
Oh, I'd love to. If a bag of money showed up under my door or on my doorstep, then I would absolutely love to. But 10 is we have in the hospital right now we have about 200 students, and 10 devices is not terrible. We have it sort of split between the hospital and the campus, and like I said, we're sort of taking it as sort of a team approach. That we have 1 or 2 units assigned to certain areas. Like we have one currently that's sitting in the ER right now, and anyone who's in the ED can use that. A couple in the ICU, a couple in the OR, and so trying to find a way that we're making 10 work. Would we be doing a lot more if we had 40 devices? Absolutely. But it sometimes is the funding issues are always there. We are extremely fortunate enough to have support at the hospital level with the HIPAA concerns. But even then, I mean, I would love to get more into the EMR piece, but that adds a whole layer of complexity. It's not just working with the hospital security and the risk management folks. Now you have to work with the EMR team on top of that, and I'm sure, which is the case for most of institutions, we're still working on getting parts of our EMR up and running, in certain clinics and certain subspecialty clinics, and so their focus, at least at our institution and a lot of others that I've talked to, is still very heavily in making sure the EMR is stable and working and adding the core functionality to it. When we say, hey, we want to bring in this module that now interacts with it, we have to do a little bit of tweaking to make it work. It's sort of another piece that they're not quite ready to tackle yet. And so having this use case where we don't need to touch the EMR and we can still be very active with it is great, because that allows us to play around in the space.
I don't know if you know the name Pedro Guillén. I'm sure Raphael knows it, but maybe that would be part of medical education in some way. You're familiar with Pedro, right, Raphael?
Oh yeah, I've met Pedro online and talked to him a few times, and he's another pioneer. He did the glass surgery the day after we did it, and so we were both on the spot a little bit, but yeah, no, they're doing very interesting telemetry and stuff. And when you mention Pedro, you have to mention Droiders. Julian Beltran at Droiders in Spain.
Right.
Julian's company, Droiders is really their company, is really the pioneers in regards to applications that really work for glass, not just for healthcare, for many other industries. Right. And it's amazing what they can do, and the streaming that they were able to do in a secure way, in a fluent way, directly to YouTube and HIPAA compliant is very it's just to applaud.
Right.
Yeah, he streamed to like 300 schools or something the first time, with the help of Julian, of course.
Yeah, I don't know the numbers, but it was certainly, it was an open stream, basically. It's a little sort of ambiguous in a way, because it was open to YouTube, but it was HIPAA compliant. So it didn't. As you know, HIPAA is an American concept, in a way, or not the concept, but the specifics of HIPAA. So so keeping privacy, it's just privacy is a pretty relative word in a way. But for us, HIPAA is a pretty specific set of rules that we have to comply with. And in other countries, like maybe Spain, maybe it's a little bit different. But yeah, they streamed out to the world, and I was able to actually be there. I was not just looking at the stream, but I was interacting with them in a sort of in a separate channel when he was doing the operation. No, not the first one he did the day after me, but but then a few weeks later he did another one that really was streamed widely and openly through YouTube with the help of Julian and his team. It's pretty amazing, and that opens the doors to what telementoring is, which is really the one of the amazing applications of a technology like glass, where you can have a wearable device stream your point of view, your perspective with your expertise or with your questions to anyone remotely with their questions or with the expertise to help you. So that is another untapped area, I think, that glass will really revolutionize.
Yeah, what I was getting at was, Warren, do you think, is it because of the HIPAA problems that you couldn't, say, have the students watch Raphael doing surgery in Maine? Is that in the future, or is that doable now, or no?
Right. I mean, it's
you can't do that right now because of HIPAA?
Correct. Right. Within our institution, when we use the Pristine software, we're able to do that, but we still need to go through. So if we do a live stream, one of the things that we need to do, if it's for educational purposes, we've done a couple tests from, say an OR to a lecture hall, but we still need to get specific patient consent for the live stream and go through that additional layer of work. But again, our situation is rather unique because we are using Pristine and our hospital has been extremely supportive. But I know of other places that even just locally, there's not a big support level from above to make that happen. But if that wasn't an issue, you'd see a lot more of this being used, and I think that's why there's a lot of physicians that are really interested in glass, or might be explorers themselves and are trying it out, but they're kind of stuck at that phase of, I can use it on a couple of instances here and there, but they're not getting further than that because they're waiting for some at least a hospital or a bigger group to make a big push to kind of create more of an easier standard of how to use glass in healthcare. But that's tough. I mean, if I didn't have this support, we would really sort of be stuck, and we'd probably not go beyond 10 units because it would be hard if we can't use it clinically.
And I think that in regards to HIPAA, it is when I talked. The first TEDx talk I gave was on telemedicine for trauma using mobile devices. Right. And when I did the talk, we were struggling with the HIPAA. Same thing, with the small. We were using iPod Touch devices because we didn't want to buy the phones to do telemedicine. And we have a network of hospitals, 18 hospitals, where we do telemedicine for trauma. And why use this very expensive Polycom or Tandberg cameras when we can use portable devices? So I talked about that on a TEDx, and a few months later, the industry produced. We were using initial FaceTime, which we didn't use really because HIPAA, and then Skype, which was encrypted but not really medical grade software. And then within a few months, the industry produced, Jabber and video and a whole bunch of other apps that were designed to meet HIPAA compliance. Right. And so the same thing is going to happen with glass. I'm pretty sure it's just going to be a matter of time, and then we'll laugh. And companies that really base their that are founded on the principle of getting a HIPAA compliant video app will, I think, suffer a little bit because it'll be common. You'll download an app that it's for glass, that is HIPAA compliant. Boom, that's it. So when that happens. It hasn't happened yet because of the limited, I think, the limited, access to glass in a way, and the high price of glass in a way, and the very slow. Glass. Google wants to really do a good job with this, and I think they'll achieve it, and that's why they pulled off the live streaming of the video streaming, because they knew that it wasn't really up to the level they wanted a Google product to be. And a few months ago, they pulled the video streaming capability, and that is coming, and that is coming big. And I know that when it comes, it'll allow much easier development of applications that then meet HIPAA compliance. So it's just a matter of time. Right.
And we're all very eager for that matter of time to happen, though.
I was going to ask you guys that. Do you think this is probably an issue for another hangout? But Do you think HIPAA compliance needs to be brought into the digital age?
Oh yeah, I mean it's a set of rules that are written at a time where none of this existed. And if you ask any physician today, I mean even our students, there's almost daily they're confronted with this sort of dilemma of HIPAA versus quality of care. And it happens if you think about just consultations, just sometimes the speed of which you can function using technology as a provider sometimes is inhibited by HIPAA. And so we have a lot of very frank discussions with patients, and there are times where we're using a patient's phone to send a picture of themselves to another specialist, or to do those sort of things just to get around some of the issues, just to expedite care. If to have to wait for a surgeon to scrub out of an OR to do an evaluation of a patient, when you could snap a photo with that patient's consent, run it up to the OR and have them take a peek at it. I mean, that saves hours on dispositions and care, but it's not really covered very easily or very clearly by HIPAA, and so I think there needs to be modification. So.
Absolutely, I agree 100%. I think HIPAA is one of the things that I would really think that HIPAA is one of the main factors why care is slowed tremendously, and also the prices increased tremendously, because you try to comply with this, and you really diminishing the amount and the quality of care you give. I have a good sort of friend of mine, Denise Silver, that you probably know. Denise Silver Warren she organizes Doctors 2.0, which is a digital conference in Paris every year. Yep. It's a sister conference to Stanford X, where we met. Right. And Denise said last year at a conference, when I was speaking there, not this last conference, but last year in June, mm-hmm. And she coined the term, better cured than secured. If you ask patients, they will choose cured rather than secure 100 times, because it is so, and they want to be relatively secure, the data and private. But if they have to choose between, being helped and being cured, they would choose that rather than not allowing a physician to send a picture of their injury or their, to be cared for. So it's pretty. It's sort of a little bit of a crazy, concept in a way, but it's necessary in many layers, in many ways, but certainly not like we're trying to apply all regulations to new technology. It has to evolve.
Right.
Well, maybe glass will be the thing that brings HIPAA under closer scrutiny, or exactly where do we stand. It seems to be an issue that something needs to be done. It seems to me, Warren, that education is suffering a lot because of the HIPAA problem, the HIPAA, issues. It seems to me, but I'm an outsider, so I really can't say what's going on inside. But do you feel? I guess you can't go on record saying that because this is being recorded. But
no, I mean, I think that there's certain things that naturally would be a lot easier if you didn't have some other restrictions. And I mean, there's always an official solution to a lot of these issues, but to get to that official solution, it costs time to do that. And so sometimes medicine is not always scheduled, and there's a lot of kind of impromptu or passing moments that are really great for education or great for intervention or collaboration. And sometimes you miss out on those opportunities as you're trying to follow official channels. And so I think HIPAA is still very well intentioned, and one of the big things too when we talk about HIPAA, there's still not at the education level a lot of discussion on what it really means to be HIPAA compliant. And we have students entering the hospital still today in brand new residents that don't really get what HIPAA is. They're always just told, no, you can't do that to whatever question they ask. And so, part of the problem I think that happens is we do a terrible job generally of really preparing residents and students for how to really function in this digital environment, and that if we could ensure that at least the providers are being more digitally professional and things like that, I think that will help kind of move the discussion along about HIPAA. So it's not just a a policy down approach. I think we need to do a better job of making sure that there aren't stories on CNN about doctors leaking photos of patients on Facebook, and when that happens, we could probably really move forward on HIPAA. So.
I just hope it doesn't retard the development, the true development of the potential of glass, because of antiquated, ossified, sclerotic rules, and that's basically what Larry Page and Sergey Brin. That's what they said. Medicine's too regulated. It's scaring them away. And the guys behind glass. I mean, not probably the exact people behind glass, but they were essentially behind it, and the regulations have scared them away. I hope regulations don't, excessively deter the development. I'm sure there's going to be some regulation, but
right. I mean,
what do you think, Raphael?
No, I agree. I think that it's a necessary evil in a way, and it'll evolve, and it is evolving, and it'll get there. I think that it slows down teaching, it slows down care as well, and I agree with Warren that we just need to prepare the newer generations to be more in line with what it is, because they don't get it many times, and it's hard because you have a generation that is brought to be open and to regard privacy as a completely different entity that we maybe do, and so but it's just a matter of time. I think we're going in the right direction, and I think tools like glass or other wearables will help the change happen.
Right. But I mean, great change is happening. If you just think about that, if medicine is slowed down a little bit by by these regulations, just look at who's picking it up. It's the consumers. It's the companies like Google that are picking up this charge. I mean, a lot of these great innovations in healthcare technology are not by medical companies. They're done by patient groups, etc. And so it's really neat seeing what they can do and allowing us to figure out how to pull that back into the medical realm again.
Cecilia, excuse me, gentlemen. Cecilia, how you doing?
Hi, John. So sorry to jump in so late.
You're not going to get 4 stars for this.
I know.
It's fortuitous you came here now. We were talking about the regulation. I was mentioning how Larry Page and Sergey Brin were scared off by the regulation of medicine, and then why they don't want to jump into it with both feet. And we're talking about HIPAA, and Raphael Grossman's here. Do you know Raphael, Cecilia?
Yes, how are you doing, Raphael?
Hi, Cecilia.
Okay, I guess you guys all know each other.
But no, I haven't had the pleasure to meet Warren before. I read about you, though.
Warren Wiechmann. He's an innovative medical educator at Irvine, around the corner from you.
I had to visit you guys because I'm right here in Temecula.
Oh, no way! I didn't realize you were that close. I was actually just reading about you yesterday. When I was on shift the other day, so I didn't realize you're so close.
Yeah, I definitely would love to visit.
Oh, okay. Well, we'll have to make a plan for that, Cecilia. Great.
Perfect.
Well, Warren is introducing glass into medical school.
It's an amazing project. I think it's and very innovating. Like, you are really ahead of everybody else doing a large. Like, I see what you were saying before, that most efforts are not by the main institution, are by doctors by themselves trying to try things out. But in your case, it's very institutional, so that's pretty awesome.
Thank you.
Warren, is it at any other schools or just Irvine?
There's a lot of schools exploring with smaller pilots. 1 or 2 units. I know if I start naming them, I know I'm going to forget a number of them, so I won't even bother trying. But I've had a chance to speak to a lot of schools looking at where to incorporate glass, and they sort of have the problem that they have 1 or 2 units and they can't get a lot of institutional support to really go beyond that. And so you're going to see for a while a lot of these small pilots that are popping up in use cases, and until either Google becomes out of the explore mode and into more of a a commercial product where the cost drops, you may not see a lot of bigger medical education projects happen until either some of the cost changes or some of the institutional support ideas change behind it. It's kind of a shame.
You think it'll follow the same path as the iPad adoption in other schools, like Cornell and Dartmouth? They're the ones that adopted the iPad, right, and Ohio State?
Right. Well, I know a couple of those already have pilots kind of going underway, so I would hope so. I mean, I think that after wearing a pair for even 5 minutes, then you sort of see the potential. And so I don't think conceptually it's a hard sell. It's more of the logistics of how to incorporate it into your environment. But the more of us that sort of tackle that problem head on, I think and are very vocal about it, then it sort of creates a pathway for other schools to follow, hopefully.
Absolutely.
You know, I'm trying to figure out how to get Cecilia involved. You know, Warren, I think like we mentioned this before, every area of medicine is going to need certain applications made. With your experience with using Google Glass in medical education, do you see any tweaks or anything you would like to change, or any particular apps that you would like to see made for medical students? Now that Cecilia's here, she makes apps.
Yeah, no, I mean, it's you sort of just asked me a giant wish list question. I don't even know where to begin with that one. But I mean, it's a matter of just leveraging the platform, leveraging the fact that it is hands-free, that it's voice-activated, that you can find a way to take lots of complex data and access it very easily. I mean, medicine is all about overly complex and voluminous data, and the iPad and even just mobile devices have done well because it can take it and now make it mobile. The question is, can we get it to the point where it's summarized or easily interfaceable, I guess, if that's even really not a word, using glass. And I think that's the big area where medicine is not very good at it. So applying good design and UI principles to accessing large amounts of data, that's gold right there. And that'll work for any topic in medicine, I think.
Mm-hmm. Okay.
John, I'm gonna have to. I'm on call, so I got finished about 5 minutes ago. So I'm gonna have to go. But it's really been a pleasure to join you guys. I'm sorry, Cecilia, I have to leave so quickly.
No.
But work calls. And Warren, it's really a pleasure to see you again, and hope to meet you soon. I'd love to. Like Cecilia, I'd love to visit and see what you guys are doing, firsthand. So, anyways, good luck and keep up the good work. Really, congratulations.
Thank you for coming by, Rafael.
Thanks, Rafael.
Bye.
Warren. Basically, I think I'm a big proponent of the Hangout, and I think that it's a perfect platform for developers like Cecilia to get together with clinicians to kind of brainstorm about ideas. I think it's a perfect platform rather than having the doctor, and you said yourself, you have 1,000 ideas of what apps need to be made. I think that's going to apply to doctors in every area. They're going to say, oh, if I just had this app made, if I can just do this. And I'm basically pushing the platform of Google Hangouts for application makers to meet docs.
Right.
It's a really good spot to do it.
Right. Well, it's working so far, John. So.
Yeah, I think it is. I think it will, Cecilia. I think.
Yes, absolutely. And some of the things we are thinking for education, particularly, we are kind of building a market, and I can't announce it quite yet. It'll be later this week that we announce it. But to give you just the concept, it's like a marketplace where people will be able to upload like the equivalent to flashcards on glass, so that specifically for students we see great potential, because I know when you're a student, you are having this massive amount of information that you need to absorb, and you have all these tricks that help you remember with different names and things, and the idea is to put a lot of that on glass and have people practice with it interactively eventually. And that's one little avenue for education in particular that we are exploring. And the other one is we talked about building like checklists and procedures, decision trees for when a doctor is doing a procedure. But we also noticed that a professional doctor that does a procedure every day, a checklist sometimes could be a little bit of a slowdown. But when you're talking about a student that they're just practicing these procedures for the first time, imagine they can be hands-free and they can follow all these things. If A happens, go here. If B happens, go there. And they follow all these. And we think as a learning tool, there's a lot of value there too.
Absolutely, absolutely. And even if you change the use case for glass, we tend to think of it still on this is my device, this is my headset, this is my equipment. We're even looking at it in places where it really becomes, say, part of a remote toolkit that you can have for, say, a remote medical team, where in a backpack is a set of glass. Where it'd be great if, for the first time you put it on, say you're, lost in the woods somewhere and you hurt down and your friend breaks their ankle. You put them on, you can try and connect, but at least there's basic first aid information that's on there that you can do hands-free as you're, trying to do this sort of workout in the field or in sort of austere environments. So I think, there's all these different use cases that we can explore that I think are perfect for these kind of areas of innovation and just playing around. So.
Yes, totally. Yeah, there's an example like CPR glass, which kind of does that for the CPR procedure, and yes, that's something that will be followed by other similar. Like you said, don't move the neck of the person if they're hurting or that kind of thing.
Right. I think there's a lot of great potential. We have medical uses right now. Then we started having kind of medical education uses. Now when we started thinking about things like outside of hospital medical uses, whether it's home visits, whether it's in an ambulance, whether it's in a plane or in a post-disaster area, I think that really opens up really a lot of what you could do with glass, especially if you're able to have a connection in those environments. Then you really, no matter where you are, you have almost an entire physician library or even an entire hospital at your fingertips with consultants and specialists. So.
Yeah, and not only like in the United States, but imagine somewhere where you have a remote location where doctors usually don't arrive there, but they could have like a nurse or someone in the community that is connecting patients with, like some places in Africa, people walk for days to get to a place where they can get medical attention.
Absolutely. I mean, if you look at just the overall direction that medical technology is going, I mean, you could take literally a backpack that has glass, it has EKGs, full vital signs that go via Bluetooth to your phone, portable ultrasound machines, and you could really have a full functioning clinic in the size of a backpack you could take with you, and that could really change a lot of these places that don't have the infrastructure that we're used to here in the U.S. or even in international kind of first world nations. You could really just change what kind of care can be provided globally with a set of equipment like that.
Yeah, it's a question of connectivity, not almost.
Yes.
Right.
If you can be connected, you can reap the benefits of digital care, no matter where you're at.
Right.
Well, Warren, I've got another hangout at 9, so as a matter of fact, I'll send both you guys invites if you want to come. It's with Albert Huang, who's doing a medical device fellowship in Houston. He's going to talk about actually, and you may be interested in this, Cecilia, he's going to talk about changing the actual structure of glass, what he thinks about the possibilities, so so it's a different shape according to the physician's desire or physician's use. So, well, Warren, I'll send you an invite, Cecilia, if you want to come. And you were late. You're going to get punished.
I might not be able to come to the next one though, but I'll watch it later.
Okay, Warren, thank you very much for coming out tonight. I really appreciate it.
Awesome. Thanks for putting this together. It's been great, Cecilia. We'll connect, and you're just down the street. So we'll talk soon. Okay.
Sounds awesome.
Great.
Okay. Good night.
Bye bye.
Thank you.